AA is our 13-year-old male transferred from an outside hospital yesterday and admitted to the PICU with a hypertensive emergency and acute change in mental status. AA has a history of end-stage renal disease secondary to medically refractory nephrotic syndrome and status post-bilateral nephrectomy with HD dependence since February of 2022, in which he had his surgery here at Lurie's. AA has a history of hypertension despite medication management and hypothyroidism. AA is followed closely by the nephrology team here. He receives HD 3 days a week with a home schedule of Monday, Wednesday, and Friday. AA received HD as scheduled on Wednesday of this week without any hypertension noted at this time. On Thursday, per mom's report, AA woke up complaining of a headache that resolved with Tylenol shortly after. In the afternoon, headaches began to worsen and he began to complain of chest and abdominal pain. Mom took his blood pressure as she's been instructed to do by her primary nephrologist, and it was 200/130. She brought AA to the closest ED. At that time, he had no changes in vision or any other symptoms. No recent illnesses or viral symptoms were observed. No other past medical history or family history. In the ED, AA continued to complain of abdominal and chest pain. He received 1 milligram of IV morphine, which brought relief. He was giving a rescue dose of labetalol, 10 milligrams, for the hypertension, which continued to persist. He also had an EKG and a troponin level, which was elevated to 0.08, and the EKG was normal. A CT of the brain and abdomen was conducted, and results were unremarkable. While waiting for transfer, AA had an acute change in mental status, which staff believed was a seizure. He received 0.5 milligrams of Ativan, which stopped the seizure. He was started on a nicardipine drip for continuously elevated blood pressure, and he was transferred to Lurie's PICU for further management and to be in closer proximity to his primary nephrology team. Overnight, AA was tachycardic in the 110s to 120s, no concerns of seizures overnight or mental status changes. Pressures appropriately dropped with the nicardipine drip. They were actually able to de-escalate, and we are now at 1 mics per kilo per minute on the nicardipine drip per the nursing protocol. His daily weight is actually increased from yesterday. Yesterday he was 37.8 kilos, today 36.3. AA has no known allergies to meds, food, or environmental allergens. He's up to date on all of his immunizations, including his annual influenza and COVID vaccine. He also received his booster last month in May. He remains NPO. He's normally on a renal diet. For his social history, AA lives at home with his mom and his dad. He does not have any siblings. He's here today with mom. Vital signs overnight, AA was afebrile between 36.8 to 37.2. Tachycardic, as I mentioned, in the 110s to 120s overnight. Blood pressures were 120 to 150s over 80s to 100. Respiratory, he was breathing comfortably in the high teens to 20s. Oxygen saturation was 95 to 100% in room air, and he had no complaints of chest pain or headaches overnight. Eyes and nose, he was positive 400 this morning. For labs, sodium was 135, potassium was 5.4, chloride was 92, bicarb 25, BUN and creatinine were elevated at 77 and 13.2. He is positive for COVID, asymptomatic. As I mentioned, increased troponin level at 0.08. He's also hypercalcemic at 15.6. His ICAL was 1.7. Coags and UA were unremarkable. For medications, AA is on a continuous nicardipine drip, as I mentioned, 1 mg per kilo per minute. He has normal saline, IV fluids going at 72 mLs an hour. His home labetalol was restarted, which is 150 milligrams BID, and his home amlodipine, 10 milligrams daily. He's also on his maintenance levothyroxine, 75 mics daily. We have held his home calcium carbonate and multivitamin. On physical exam this morning, generally AA was awake, alert, well nourished, lying in bed, responding very appropriately to commands. His affect definitely was flat. No seizures. All of his cranial nerves were intact. HENT said it's normal cephalic. Sclera was white. Pupils are equal, round, reactive to light. Mucous membranes are pink and moist. His neck is supple with no enlarged thyroid palpated. He has a natural airway. For cardiac, he was tachycardic overnight in the 1-teens, normal S1 and S2 and rhythm. No murmur detected. Upper and lower extremity pulses were within normal limit, and his skin is warm to touch and pink. Respiratory standpoint, he's breathing non-labored, clear and equal bilaterally. No wheezing or other adventitious breath sounds noted, and no coughing. His abdomen was soft, flat, non-tender. Hypoactive bowel sounds were noted. Musculoskeletal system, he had full range of motion in all extremities, no deformities. Capillary flow was less than 2 seconds. He's got equal strength and tone. No lower extremity edema. Skin, I don't have any concerns. No rashes, dry. For access, he has a right chest double lumen CVC for his HD line, and he's got 2 peripheral IVs, both in bilateral ACs. My impression is this is a 13-year-old male with end-stage renal disease and HD dependence. He's on day 1 of PICU admission for management of his hypertensive emergency and mental status change. He is clinically improving with his blood pressures and still with ongoing hypercalcemia. For the problem list, we have health maintenance, nephrotic syndrome, chronic kidney disease, hypothyroidism, which is acquired, hypertension, and hypercalcemia. Differentials for AA include excessive calcium ingestion, possibly at home from the home supplementations. Per his primary nephrologist today, as we linked up prior to rounds, she had concerns about the suspected intentional ingestion, as her team does have some concerns about depression. Another differential would be hyperparathyroidism, given his chronic kidney disease and his hypothyroidism, and just having home calcium supplements. So my plan by systems: respiratory, we're going to keep everything the same, continue to monitor him on room air. Cardiac, we already restarted his home labetalol and amlodipine. We're going to discontinue the nicardipine drip. We're going to maintain his systolic blood pressures in the 1-teens to 140s. We're going to continue to monitor his hemodynamics and perfusion, and we will also recheck a troponin. For neuro, we're going to continue to monitor his neuro status. FENGI, we're going to resume his renal diet, low potassium, low sodium, low phosphate. He will get his scheduled HD today while inpatient. We're going to monitor strict I's and O's, maintaining a fluid max of 1 liter. We're going to resume his home supplements of the multivitamin and the Renalpha. For kidney, we're going to continue to monitor his hypercalcemia. We're going to hold the calcium carbonate. We're going to check a vitamin A and a vitamin D and parathyroid levels, as well as his thyroid levels, TSH, T4, T3. We're going to repeat electrolytes and also a serum calcium and an iCal tonight. ID, we're going to continue to monitor for signs of infection and keep him on COVID precautions. Heme, I don't have any active concerns, but we'll continue to monitor. We're going to keep all of his access right now. From a social standpoint, the nephrology social worker is going to come by to do a HEDS assessment and a depression screen. For dispo, we can plan on transferring him to the floor if he remains off the nicardipine drip for the next 3 hours, maintaining his systolic blood pressures at his goal. And obviously if there are no changes in his mental status or worsening condition. Thank you.